A warm welcome to this talk, and it's really quite an important one, and I'm so pleased to welcome Professor Angus Dalgleish. Professor, welcome and thank you for coming.
Thank you.
Now, Professor Dalgleish is a professor at St George's University, London. I'm not going to go through all of his qualifications, but he's a Fellow of the Royal College of Physicians in the UK and Australia. He's a Fellow of the Royal College of Pathologists. He's a Fellow of the a Fellow of Medical Sciences, as well as having an MD medical research degree. Really quite impressive. And he's had 563 publications. I don't know how you fit that in one lifetime, but that's what he's had, with over 25,000 citations. And I believe, Professor, you're still working as a cancer doctor. You're a consultant oncologist.
I am indeed, yes.
Yeah. Now, what's concerning you at the moment? There's some observations that you've been making that are concerning. Just, if you don't mind, tell us about your observations and what your concerns are.
Well, I began to notice, I've been doing melanoma patients for, well over 2 decades, and probably 3, longer than I can think. And I started working with these patients because nobody else wanted to work with them because they were very difficult. They didn't respond to chemotherapy. And so I was very interested in the history of immunotherapies working. So I basically immersed myself in this and started doing the first cancer vaccines. First of all, collaboration with Donald Morton of CancerVax and the John Wayne Institute in California. And I was the only collaborator outside the US for many years. And then I started working with a whole range of cancer vaccines. And the ones that I'm most interested in, the ones that stood the test of time, are actually the simplest. They're the heat-killed mycobacteria ones, etc. Well, so while doing this work, I began to notice things that, why do some people respond very well and others not? Well, I won't go into the details, but the first thing was clearly it was vitamin D. We suddenly realised we were dealing with endemic vitamin D deficiency, and if you corrected it, they started to respond better to immunotherapy, etc. So I've had some patients on immunotherapy for several years, long before the new immunotherapies were approved, the Ipilimumab and the Nilos and Pembros, etc. And I started to notice that some of these patients who were coming up to, they're over 10 years, 15 years, 20 years, they were suddenly relapsing. And they were presenting with relapse disease after years of not having any disease. Now, this was not unusual to me because I'd seen it before, but I always want to know why.
Of course. These are patients with malignant melanoma, malignant skin cancers.
I noticed that the patients who had relapsed before, that they all had a history or reason of something which caused a significant period of immune suppression, such as a significant upset, bereavement, divorce, bankruptcy, etc. And I saw it. But there was an explanation for it. Now, more recently, I started to see it in more patients than I was used to in a short period of time. First of all, it was 6 patients I counted who all came and they'd had to have another lump out. We had to investigate and found they got relapse, etc. And I started to ask the question, have you had bereavement, divorce, this, that, and the other? And then it twigged. They'd all told me that I've had my booster. Yes, I've kept up to date with my boosters, and it suddenly began to twig, because I was very against the booster program. I put it quite basically. I've done over 30 years research into optimizing vaccines and the immune response, and I came to the conclusion that the vaccines that they use are obsessed with antibodies, and I'm not. Actually, I'm not interested in antibodies because it's the T cell response that you want. It is the innate T cell response. And as a cancer doctor, I noticed that the innate T cell response starts to decline at 55. and by 70 it's fairly much in your boots. It's gone down a big ski slope. But if you superimpose the rise of cancer treatments, it rises at the opposite rate, forming like a butterfly wing. So it started to ask, was it cause and effect? And then we found that we had agents such as the new one we worked with for a long time, is IMM 101. Heat killed, it really boosts the innate immune response.
This is just a simple bacteria that's been killed and injected.
Yeah, I mean it's the other end of BCG, and it came out of BCG work. And it's very interesting is that BCG it was found to boost the innate immune response. And here's the clue: if you give it more than twice, it basically starts to ruin the response and just boosts antibodies.
So this BCG was used to prevent tuberculosis.
BCG vaccine for tuberculosis.
Yeah.
Now, the heat kill mycobacteria, they don't do this. If you keep giving them, they keep boosting the T cell response. They don't induce an antibody response. So as such, I thought this is a very useful agent. I've been doing clinical trials on it. And one of the things I did notice right at the beginning of the COVID was the patients are already telling me that, well, that they're often their wife or husband would say, I don't know what it does for the cancer, but I've never seen them go through winters and not have colds or flus all the time. They seem absolutely fit. And then I realised this is the innate immune response. They weren't getting flus or colds. So I predicted this would be a very good front line for COVID. And sure enough, it was. At the height of the first wave, when there was no vaccines mentioned, none of these patients caught COVID. And yet their average age was all over 65 was the average. And they all were at risk because they had stage 4 melanoma. They had a full thing. None of them got ill. They might have had a very mild COVID, where other people all around were going down very badly with COVID, mainly the staff.
So these are people in your trial, Professor, that were simply given this microbacterial, very simple, killed bacteria vaccine.
Yes. Yeah.
And even though it's a specific form of bacteria you were giving, that was stimulating an innate immune response that was working against a wide variety of different viruses.
So you got it in one. So that was the environment I was in. Yeah. And then we come up with the vaccine comes in. And as I said, I had a lot of experience in this. And I came to a conclusion, if you need to give more than 2 shots of a vaccine, it doesn't work. That would be one of my general rules of vaccine. And I think that's been proven to be absolutely right. The boosters are worse than useless. And they should never have been given. If they were going to be considered, they should only have been given to people who you knew their immune status. You should have measured it. I went on to a TV live debate with other doctors, and I said, why the hell would you give a booster to a vaccine that people have already had without measuring if the response was satisfactory? Because they might not need it. Because if they do not need it, you'll make things worse. And that was from the BCG example, to name but one. So people just dismiss me. They wouldn't enter into proper debate about this. Said this is an emergency. No, it wasn't an emergency, because the next thing I realised, especially when the people who had the boosters were actually often saying, well, I never had the COVID till I had the last booster. There were all sorts of clues like this. But it was in this group who were getting the relapses, they all mentioned they were having the boosters, as if they'd done the right thing. Mm-hmm. And I suddenly twigged. I thought, it's the booster that's leading to the relapse. And as a scientist, I wanted to know what the reason for that is. Well, I know that you've only got a limited capacity in your immune system. If you boost with another vaccine to harness half the immune system to make antibodies to a virus that no longer exists on the planet, probably for 1 or even 2 years, you are going to weaken it. You're going to reduce the front line, and then we got the papers coming out that beautifully confirmed it. They showed that the booster, you no longer make IgG1 and 3 neutralizing antibodies. You get a subtype switch to IgG4. There's a very detailed, excellent paper showing this. Well, an IgG4 subtype is the lasty one because it's a tolerogenic. It basically said, I've had enough of this abuse, we're switching off this assault on us with these agents. But it gets worse because it also suppresses the T cell response. And there were some people who did a really nice study. I can't remember it offhand, but I actually presented it in a presentation I did yesterday. The first group who showed that the T cell response crashes after the booster in cancer patients, whereas it's not perturbed in the first two, but the booster leads to a massive reduction in the T cell response. Not in all of them, but in many of them. Well, to me, this was enough because we know for immunotherapy, I knew from my work of over 20 years before we even started using these checkpoint inhibitors, IPI and Nivo, etc., that the T cell controlled this disease because I only saw relapses when there was reason for perturbation. Now we had a booster that was clearly causing perturbation, which if it was transient, I wouldn't mind, but it was a lot more than transient, especially when the patient said, well, I've had 5 vaccines. I mean, I was beginning to scream, what are they doing? What are they doing? And I reported all this to various mediums. I wrote a paper to the BMJ. I thought the BMJ had actually started to publicise things which are a little bit, concerning to doctors rather than censor it. And basically, I found, I was the first in the UK to point out that the virus escaped from the lab. And to me, it was completely obvious because it had inserts in it that one of them could occur naturally, not 6 all around the receptor binding site. No, that wasn't. And for my pains pointing this out, I thought, well, this is brilliant. We can challenge the nature science. So every single journal turned down papers pointing all this out, saying it's not in the public interest. I mean, basically, this was an Orwellian Ministry of Truth had taken over.
This is after you've had 563 previous papers published over a distinguished career. I can't think of a doctor who's more qualified than you offhand, actually. So after a distinguished career and all this work, 563 papers, you couldn't get published anymore.
Well, it's not so much the quantity, but there's a quality issue too, I would say. And I've never really wanted to publish things that were a waste of time or irrelevant, but to add to stories. But I've had a lot of stories. I had a big presence in HIV, and I discovered the receptor. That was the first author with colleagues doing it. And that led to me being very recognised as a serious virologist and scientist, which to me was very surprising. I was at all the early HIV meetings and I bumped into people. I mean, often I was a guest of Bob Gallo and I bumped into Fauci, what have you, and all the others. And I thought, well, these guys really at the field was talk about publications. They were publishing in Nature and Science every 2 or 3 weeks, it appeared to me, and I was just lucky to get 1 or 2 in, and it just seemed to me that they were kind of gods in this. And it took me quite a while before I realised, actually, no, they're not. And I came to the conclusion, and I'll say this because this is my personal opinion, that Fauci's not very bright. He thinks he is. He's a very good diplomat, but he's actually not very bright. Because I pointed out in sessions when he shared that, is you'll never get an HIV vaccine if you use the entire envelope. There's 3,000 antigens on it. You throw that as an antigen at a naive immune response, it's going to pick out the dominant responses. And the virus has evolved that the dominant responses will be against bits of it doesn't give a damn about. Mm. And I also predicted that it's a decoy, that the Achilles heel lies at the heart of this. And by giving the whole envelope, you'll never allow the body to see the Achilles heel. We worked it out. I won't go into that, but that's a big chunk of papers that I did, which I felt never got the recognition that they deserved. I thought they were far more important than the CD4 receptor. But the bottom line of this led to me collaborating and my group with several people. We had a European collaborative group which produced lots of papers and showed that the virus never causes AIDS unless it activates the immune system first. And whether it activates is determined entirely by your HLA type. And that those people who never
That's the sort of tissue genetics you're born with, isn't it?
Absolutely. And those people who had long-term infection and didn't seem to get ill, we predicted they must have a certain HLA type. And one of the guys that worked with me, he was very hot on this, actually predicted the HLA type early on from his computations and modelling. And the modelling that my colleagues and I did in those days, unlike the people at Imperial College who don't seem to model anything remotely correctly, this turned out to be very true, because he predicted that HLA-B8 people would get AIDS quickly, and those with HLA-B27 would get it very slowly if this Achilles heel was the bit driving the disease. And it was proven in a big MRC survey that those were the only two significant things. B8 fast, B27, they hardly get it. And based on the back of that, I predicted, well, there's one group of chaps who never get AIDS, however much virus you give them, and that's the chimpanzee. I reckon they must all be HLA-B27 or similar. It took 5 years to persuade one of the people who had a large chimpanzee colony to do the HLA, the genetic immune codes, and they were all HLA-B57, which is sort of a brother of B27. So absolutely right. And the only conclusion from that was they'd all been eliminated in the past, in the wild, by HIV. So you're dealing with a survivor population.
Yeah, absolutely. Natural selection.
We had a big understanding of this. So. And working with my Norwegian colleague, who came up with the same idea, do not use the envelope, too much information, decoy, Achilles heel, etc. He identified 4 Achilles heels, made them in peptides, asked me to join him because of the immunological expertise and the HIV, being in the HIV field. He did that, very successful HIV vaccine. Never achieved its primary goal in trials because the primary goal had been set wrong. Had it not been set wrong, it probably would have been much more successful. We haven't given up. I've not given up. I think this is the best HIV vaccine. But what really got me about the establishment is that the Gates ask you, the MRC asks you, well, they all ask you. And we put this proposal in and said, the envelope vaccines will never ever work because this, that and the other. This already works. We've had it in humans and it reduces the virus load very well. We want to just modify it, optimise it, and we reckon that you'd be able to give this and take people off anti-HIV drugs for months and months at a time, which would be tremendous for Africa. And we were always rejected. It's a very clever idea, etc., but we don't need a plan B at the moment because we've got a great big worldwide clinical trial and this looks like it will be positive. That one, 1, 2, 3. The third time, they still said it'd be positive. I mean, was it Einstein who said the definition of an idiot is somebody who keeps saying the same thing expecting a different answer?
Sounds like the sort of thing he would say, yeah. So your HIV vaccine, what does it actually target?
Well, it was targeting the this is very relevant to COVID, by the way. It targeted the nucleus, not the envelope.
Right. So the proteins in the nucleus of the HIV.
It ignored the envelope. We subsequently optimised it by adding in the one bit that drives the immune activation, which I had spent years identifying. We added it in and it makes it even better. So it really works well now. Now, the thing that really annoys me was and we're talking people spending billions. I mean, Genentech was involved, NIH, the Gates Foundation, Garvey, Harvey, this, that. We approached them all and they all brushed us off. We know what we're doing. And each of those big worldwide vaccine trials, it was the same thing being presented, just different technology. So it made me realise, do not fall for technology. Now, listen to that, because this is what we hear all the time. And, 10 years ago, it was DNA vaccines. They're going to save the world, this, that and the other. they work brilliantly in mice and guinea pigs and things, and dogs. But as soon as you get bigger than dogs, they do not work.
These are the adenovirus vector vaccines.
And DNA, and so it then everybody said, "Oh, the RNA is the thing." Now, I don't think RNA is recent. I mean, this is the other thing. And when I was giving a thing saying that I actually blame the RNA technology for making the boosters even worse, I had people who were involved with them say the attitude was, "Well, what do you don't know what you're talking about. You're just a clinical, oncologist." No, I mean, I sat on the scientific board of a company that called itself the messenger RNA cancer vaccine company for 5 years. I left 6 or 7 years ago, and they had everything in place. I mean, they weren't able to take it forward. So the messenger RNA industry has been there waiting for an excuse for a long time, and I think that's why it was the pandemic was the excuse to use something to save the world, etc. This was the kind of thing. But when I go back again to the patients who've relapsed,
the melanoma,
I go back to that. I put it all down to the immune suppression caused by the boosters. But I've seen some later relapses which you say, well, perhaps the immune suppression would have recovered by now. And then you become aware of that this is where the RNA comes in, is that to me, I was always suspicious. I saw all these reports and they were always pushed aside, and many publications were pulled. I mean, the Orwellian censorship by whatever it is, I don't know. But whatever it is, the censorship's been awful. But now there is enough data out there, there's enough people cried foul, that the quality control of messenger RNA viruses, which I believe was always the big issue. I mean, it was a big issue. Has not been solved. And you've seen all
the quality of the vaccines, yeah.
There was for the first time, mainstream media, an article in Spectator Australia actually went through that not only is the quality control awful, but it's contaminated with DNA plasmids. One report up to 350 odd times, with sequences from the SV40 promoter. Well, the SV40 is an oncogenic promoter used in cancer development in mice. And, so when I say, what the hell is that doing in an RNA vaccine, you have to ask. Because the presence of that and the presence of DNA means it can integrate. Surely that's not possible. Well, you don't have to go very far into the literature to find people reporting that the spike protein is integrated into all sorts of different tissue. And for Registry, they said that it stays at the point of the injection site and there's no way it spreads. Oh, that's all right then, it's safe. This turns out to be a complete lie. It's been identified at autopsy, it's been identified everywhere. Yeah. And this is the other thing with patients. I can't get autopsies on these patients to prove this. It's quite incredible. But a colleague who had an explosive cancer, a colorectal, basically at surgery sent the pieces away, the metastases away, and spike messenger RNA from the vaccine insertion was confirmed. So it is. This to me is quite frightening that this is occurring. And also that there's been this, we don't need to do post-mortems on patients dying from this. It's like it's from on high and they just won't do it. I pleaded for one on the patient who died from explosive melanoma, who said, I never felt well after the booster. I just felt chronically unwell, and then the melanoma came exploding back. They wouldn't.
Had the patient's relatives consented to a post-mortem?
Oh yes.
So just a minute. You're one of the most senior doctors in the country. You wanted a post-mortem. Yeah. The relatives had consented to a post-mortem, but that was refused. This is just unbelievable.
It's overruled, yeah. Unbelievable. It is
overruled by whom?
Well, perhaps it had something to do with there was a report which got into the Lancet of people who died after vaccines to see whether it could. I don't know if you saw that. It appeared in the Lancet, but then it was pulled. It was pulled very quickly. The explanation given, it wasn't properly peer reviewed, which tells you there's not peer review is over and dead. I mean, basically, it's not politically within the political mantra, and this is what really frightens me. I went to do an interview along these things, into a mainstream media channel, and the guy warned me at the beginning. He says, I have to be very careful the way I ask you questions, and please don't be put off that I probably sound fairly hostile. And I said, well, I'm very happy to discuss facts, this, that and the other. But he said the government have made it a crime to criticise the vaccine programme on the media. And I said, I'm astonished, but actually thinking about it, I'm not surprised, because it explains why nothing is being discussed. Well, that's someone in the mainstream media told me that they're actually told they can't do it. And as you know, the Ofcom basically waded into Mark Stein on GB News, but basically querying just that. I mean, it's the job of the press to raise questions. And that actually is my job. I mean, I was carpeted for saying this without proof, and I'd actually have to present proof. Well, they won't let you get the proof, that's for the start. But based on this, one of the things that I did do, because I have been with many others, particularly Ross Jones and Claire Grant, we have written many, many letters to the people who need to know about all these issues. There's particularly Ross about children, which I joined her 100%. I said there's absolutely no need for a vaccine. This vaccine, actually, I said for, at the beginning, they said only for people over 70 and who are ill. And when it came down to 40, 50, I said that, there was no need for that because we were getting this myocarditis signal. Why did they carry on persisting going down? At any rate, that's another story. But we reported all this to people like Chris Whitty and the Department of Health, the NHS, the MHRA. We basically got no engagement, which I think is an absolute disgrace given the seriousness of it. And so I was told to say, have you been reported to the Counter Disinformation Unit, which is set up by
the government?
The government, yeah. And it said you can do, if you go through this particular process, they've got to let you know. And I was told by somebody who had done all this and found that they had been reported for it. So I decided and went through this process. I mean, I suspect I have been reported more times than anybody else because I started with a virus. I appear at bang, 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 criticising the virus, the origin of the virus. Lockdown, bang, bang. So I said lockdown was moronic. And I said, you should never lock down when you haven't bothered to quarantine. And if quarantine doesn't work, there's no point lockdown. And it never works for airborne diseases in all this. Just as a cancer doctor, I said, you lock down the cancer, that death rate in 6 to 12 months to 2 years will go through the roof because they won't be getting screened and early treatment. And I pride ourselves, we were bloody good at that then, but this lockdown, the collapse of the NHS has destroyed that. I mean, it's really, really tragic. So then I found actually one of the things that I was, that one of our letters handed into, including Chris Whitty and everybody else, this, that and the other, that this resulted in another complaint to the CDU about me the next day.
Counter Disinformation Unit.
So what the hell are they doing? As you say, I'm in a far, far better position than any of these people. I can't believe the complete, unbelievable, I've got to choose my words very carefully, But to rely on Sage, you get better information from the people running Battersea Dog Home, infection control, in my view. I mean, I just couldn't believe that. And Chris Whitty, I mean, I cannot believe the stupidity of the statements that he has made. Right from the beginning, we told him about vitamin D, this, that, the other. And he came back, they had the contact, and he said there's not enough evidence to do anything about it. I mean, not enough evidence. It is beyond belief. And then, when we challenged him on doing children, he says, you've got to vaccinate the children in order to protect the parents and grandparents. Well, that one sentence, he revealed acres of stupidity. First of all, you don't vaccinate people to protect other people. That was the first thing he got wrong. And then by saying to protect the parents and the grandparents who had already been subject to this vaccine battering, you've admitted it doesn't work. It's unbelievable. And so, I mean, I think Chris Whitty said one or two things that made a reasonable sense earlier on. He said, well, you can't really introduce vaccines unless nothing works and the virus is really lethal, that kills young people, a third of them, which is absolutely true. So why did he allow a vaccine program to be rolled out for a disease that only killed old people, in my view, just brought forward death by about 3 months, and didn't actually kill anybody else any more than the random viruses, the flus, etc., do it? I think, and I call them this, and I think there has to be accountability. There has to be this Hallett inquiry. It actually should be feet to the line. This was, it was in your watch, your charge. All this stuff now is because you didn't do things. And I think, why didn't Whitty resign? Why didn't Vallance resign? They're like a load of useless footballers passing the ball around the back because they can't be bothered to sort the team out properly. They just pass. They're blaming everybody else. I mean, I think this inquiry is just a farce and a whitewash. And by the time they come to any conclusions, the people will it'll go on for so long, they'll have forgotten what it was all about, and the people will be completely retired or dead or God knows what else. It's all. And I think they should be the people who should have intervened, because they were there, they knew about things, and if they didn't, they should have got the right people in and resigned.
Mm. Going back to your patients, Professor, with the melanoma, there's this perturbation in the immune system. Now, have you seen aggressive? Is the melanoma become more aggressive, a sort of more virulent melanoma as a result of the perturbations, which may well include the vaccine?
Completely. In fact, it's my colleagues who came up with saying, we're seeing this too. It's absolutely explosive. They coined this word explosive. And my colorectal colleagues are seeing this now. They're talking about explosive presentations of colorectal cancer in young people, particularly like they've never seen before. And it was when one of those that the integration of the spike protein in their tumours.
So it's almost like a new disease, explosive colorectal cancer of the young.
Yeah.
It's
I mean,
terrifying.
why is it explosive? So they are presenting, and it's already in the liver and the lymph nodes and the lungs, whereas normally
it's already metastasized.
Yeah, this is a process that when you put them under pressure, it gradually escapes. This is a slow process in most people. Explosive is extremely unusual, and the colorectal surgeons are all reporting this.
Now, have you seen any cases that you probably wouldn't expect of lymphoma, cancer of the lymphatic system?
Oh, absolutely not. I mean, I don't do lymphomas as in the clinic, so that's the first thing. But I'm hearing people who've, after their booster vaccines, have gone down with lumps in the neck and things like that. And I found a colleague works somewhere else completely. And I bumped into them and I said, how are you? And I said, oh, I'm okay, but I've developed some lumps in my neck, and they've been diagnosed as lymphoma. And I just, trying to be sympathetic, said, God, I wonder what earth caused that? And the patient said, oh, apparently it's due to the vaccine. That's what my oncologist said. And I said, but this is the reaction I'm getting everywhere. And yet, when we report it higher up the chain, we're told it's anecdote to shut up and not cause panic amongst the patient. At any rate, that person told me that 3 of her friends out of a couple of dozen had all had the same thing. It was quite amazing. Then I found somebody else locally had had a lymphoma diagnosed. Then I found a close member of the family had developed a leukemia, and that was after the booster vaccine. Now here, I want to point out that quite a few people, especially my age and etc. around, probably have low-grade B-cell disease, lymphomas, leukemias, etc.
Myelomas, and
And yes, and it's maintained under control because of the good, healthy T-cell surveillance. It keeps it under control. So when you give a booster and you start to find these B-cell leukemias and things coming more common, you don't have to look hard to work out what the pathogenesis is, why they've suddenly appeared. But my other colleagues are pointing out that they're seeing more renal cancer too, a lot more renal cancer. Now, renal cancer and myeloma were always lumped together as being tumours that seem to respond to immune therapy. They were both the ones that responded to interferon and interleukin-2 before we had specific therapy. So that again would fit the T-cell perturbation control theory.
Mm-hmm. And are we talking about what sorts of leukemias potentially are we talking about here?
Well, B-cell ones. So, I mean, one of the ones specifically had a sort of rare subtype. It's called mantle cell. But that all fits into the more chronic.
Remind me, please, is that the myeloid type?
Yes.
Yeah. Right, thank you, yeah. Now, you mentioned before about the S40. Now, this is the simian virus, I think, isn't it? Simian virus 40.
Yes.
Now, am I right in thinking that coincidentally infects monkey kidney cells, which are cultured?
Absolutely right, yeah.
And then those cell cultures are used to make the DNA, which is then used to make the RNA, which is in the vaccines. Is that the way it works?
I'm not. In theory, yes.
Yeah.
I'm not completely au fait with how they are doing it. I mean, it's all sort of commercial secret.
Yeah,
but
that's true.
Now you find these sequences in both Pfizer and Moderna, you can start to put it together.
Yeah.
I mean, if it was just in one batch, somebody very early on, very astute, pointed out that there were terrible side effects in some people, even in the first and second.
Yes.
And then they found that there was a massive difference in the batches. And so if there was 3 big batches, one batch would be responsible for 90% of the side effects.
Yeah.
So we know then that this is a big quality control issue going on. And so if, as they say, they find these sequences in lots of different batches, it does suggest that.
And I think one of the bacteria used is E. coli, which of course is what we call a gram-negative. And if there's any contamination from the gram-negative cell walls, that would make people pretty ill as well, if that was the case. I'm concerned, dramatically concerned about what you've seen already. What possible implications could this have for cancers emerging over the next few years?
Well, obviously, I'm aware of quite a few patients who've been bullied into having a booster and then another booster just to be safe because you're at risk. I think this is highly unethical because, and I have seen it, a communication. You are required to contact your GP immediately and arrange for another booster and things like that. That is totally, utterly unethical. It's non-GMC compliant. In fact, it's nearly Nuremberg trial territory because there's no informed consent. There's not even any justification that the booster's going to do these patients any good. In fact, completely to the contrary. And the big thing is that they wanted you to have the vaccine, remember, to protect everybody else. It doesn't protect infection at all from the Cleveland study. I know the big Cleveland study was updated. It first came out earlier this year, was updated in September, and they've confirmed if you have the booster, you're 3.5 times more likely to get COVID than if you don't. So I would put that into grievous bodily harm territory, not necessary medical prophylactic treatment territory. I mean, why on earth would you want to do that? And the only way that that is causing them to be 3.5 times more likely is that it has perturbated the immune system along the lines I've said. It's used its resources to fight viruses that don't exist. It's making lots of useless antibodies, which are actually contributing to a phenomenon called antibody-dependent enhancement. And the same Cleveland thing has reported that the vaccine companies say, but this is a great technology because all the new variants we can make a new vaccine for. I'll give you the new variants and we can give you 2 variants at once. There is no evidence that protects you whatsoever. In fact, in all the mice work, there's evidence it will actually do more harm by doing it. And so first of all, this type of virus, we have antibody-dependent enhancement, which I think is clearly going on.
Yeah.
But secondly, to explain why they're so useless, is that I published with some other colleagues, this is a completely different group from the origin of the virus, going over the sequence and finding out these have all been genetically put in. I published with another set of colleagues is what the history of coronavirus vaccine is and what lessons can be learnt from it. Well, the lessons that can be learnt from it is no coronavirus vaccine has ever been shown to be of any use at all. And that's why we don't have one for the cold. And more importantly, they would love one. The vets would love them, but they just don't. They just don't work. And the main reason they don't work is the coronaviruses have this phenomenon. Once the immune system's seen it, it locks in. It's called immunological imprinting or antigenic sin. So when you do any variation, all you do is boost the response to the first one, and that would explain why they're so useless and why they're letting all other variants in through the back door. And other people have said that we probably wouldn't have had the problem with the variants if it hadn't been for the vaccine program in the first place, which in retrospect, everybody said, well, at least it protected loads of people, unless you're Neil Ferguson and it suddenly becomes 20 million or something like that. But I don't even buy that anymore, because it came in when everything was dying out and new variants were being induced, probably by the vaccine thing. And one of the big important chapters was in the places that got the new variants the quickest were those of the most intensified vaccine programs. And one of the first ones to come out that was completely different was Omicron, which came out of South Africa. And the South Africans beautifully described that this was a much more infectious agent, but it wasn't serious. Don't worry about it. Don't do this, that. It is not a thing, just don't worry about it. And by the way, we've done our work. It makes no difference whether you're vaccinated or unvaccinated, whether you get infected, whether you get ill, whether you go to hospital, whether you die. They had all that data on the plate. Again, they communicated with the government, Whitty, and all these people who decided that they're probably not that clever and got it wrong, and they persisted with lockdown and every other lunatic thing.
So all South African science got it wrong.
Yeah, and of course, in retrospect, they got it 100% right.
Yeah.
And I must say, after hearing them being interviewed, I knew they were completely right, because they're absolutely switched on. Mm-hmm. And people who work in that environment tend to be a lot brighter than those who end up in Whitehall.
Indeed. So giving repeated booster doses of vaccine produces more antibodies. Have you got time to tell us what antibody-dependent enhancement is? What is being enhanced by these antibodies?
Well, as I mentioned, the antibodies they're no longer neutralising because they were developed in order to attack a virus. And so that's long gone. So you've got all these antibodies and they attach to the other viruses because there's some bits the same, but they don't neutralise it. So by attaching to it, they have their antibodies sticking out, so they're more likely to be gobbled up by the macrophages and things and brought into the system.
So it makes them more likely to go into cells.
It makes them more likely to go into cells.
Yeah.
It's very well described, and it's the bane of trying to produce vaccines against things like dengue fever, long since known, and there's several others of that ilk.
Mm-hmm. And of course, once the antibody has helped the virus into the cell, the virus can then reproduce within the cell.
Yes.
Yeah. So the government are building a new plant in Harwell Science Park, just near Oxford, to produce 250 million doses of mRNA vaccine per year. As far as we know, there's another plant near Melbourne, we believe, in Australia, to produce a couple 100 million doses per year. There's another one in Canada. Is this a good idea?
Have to think very carefully. I read today that Germany has ordered the destruction of millions and millions of doses of vaccines, having come to the right conclusion. Switzerland is the same. Switzerland binned all their vaccines. I think they've been hoodwinked about this. I mean, we did need a good facility, but now the last mass production we need is messenger RNA.
Yeah.
I think it should be put in totally into the bin. A lot of people hate me for this because they've put so much intellectual everything in it. But I mean, if I was 10 years ago involved with scientific things, committees who had everything sorted out to go in, and they're talking about cancer vaccines, so the safety issues aren't the same as giving it to every man and his dog.
Yeah, it's just chalk and cheese, isn't it? If you've got someone with who's perfectly healthy and you give them an intervention, you've got one set of risk-benefit analysis. If you've got one of your patients, for example, who's gravely ill with some form of cancer, then clearly you're going to be prepared to take a bigger potential risk because the risk from the cancer is so much bigger. It just seems a completely different equation.
It's proportionality.
Yeah.
Certainly no proportionality with the messenger RNA risk and world populations, saying you are preventing them getting a disease, which if it is going to kill them, they're going to die at any rate. The vaccine is going to make no difference. Yeah. I mean, we've all lived through, I mean, the COVID thing has made us forget just how lethal some of the flu epidemics have been. I mean, 30,000 a year was not unusual when I was a junior doctor having to cope with things. So we didn't close down the country for that.
Mm-hmm. That's all I wanted to ask, really, Professor. Just got one. We do plan, if you would like to, I'd like to do another video at some stage on viral origins. I don't want to do that today, but that's an interesting one. But do you have a particular blood level that you like to titrate your patients with cancers? How high do you like their vitamin D levels to be?
Oh yes, I've done an awful lot of work on that, and then I came to the conclusion that the normal level, which the NHS and the doctors like to bark at you, normally you don't need to do anything, this, that, and the other, is not normal at all, because it's the normal population which is endemically low in vitamin D. That is the problem. It means you're like normal for people with low vitamin D.
It's normal for people that are low. Yeah.
See what I mean?
Yeah.
So I did a lot of work, and like most things, I included myself in this, and I measure my own vitamin D and vitamin D, etc. And I read wisely. I mean, and I must give full credit to David Grimes and David Anderson, who really, I mean, if anybody deserved the Nobel Prize, they should have had the Nobel Prize for the COVID pandemic, because I had lobbied strongly, independently, and then I found out they had too. And so ignore us and the many others who probably did the same thing. I think is medical negligence, what the government, total medical negligence. Any rate, not forgetting your actual question, is I came to the conclusion that I want all my patients to have a vitamin D3 level over 100 nanomoles per litre, not 50, as the NHS seems quite happy with. I managed to get my own hospital to accept up to 75, but for my patients, I want it to be over 100. It makes an unbelievable difference.
So that'd be about 40 in American nanograms per mil.
Honestly, you've got me there.
I think you divide. I was trying to do it. You divide by 2.5, so I quite. So it's round about that. But over 100 nanomoles per litre it would be your preference.
Absolutely, yes.
Yeah.
And it really does make a big difference.
And that might mean giving like 10,000 units a day to bunk it up over a few weeks.
I mean, the other thing, there's 300 genes involved in absorbing and producing the active component, the vitamin D3. Most people are going to have a mild deficiency in one of those gene productions at some stage. Right. So I've seen people who have had very low vitamin D, and I'm staggered that they have outdoor lives, they have great nutrition and everything like that, and yet they've got very low vitamin Ds. Because I have to know explanations for all these things.
Of course, you're a scientist.
I'm scientist. So let's accept it. And then I said to this guy, but I said, you're super low. It's like you're deliberately avoiding vitamin D. Tell me what you do, because you're always out cycling in the sun and it's so fit and exercise. And he says, well, I get up in the morning, I have my breakfast, and then I slap on my sun cream and this, that, and I go for a bike ride. I said, what factor do you use? He said, 50. Right. Well, once I knew 50, I started asking other people 50. 50 is again...
complete block. It's like wearing a shirt.
Because I found that people using factor 50 were having super low vitamin Ds, even if they're out in the sun all the time. So it's far too strong, and that's another global thing that the NHS and people should do. They should remove factor 50. It's actually dangerous because it completely blocks out the vitamin to cope with vitamin D. So anyway, so that's how, going back, I think that 100 nanomoles is to aim at. Some people, and let me put it this way, I've seen nobody near 100 who hasn't been taking supplements. With one exception, and I won't forget it. I said this, he was quite an elderly man, he had melanoma, we treated him quite well. And I said, you know, we need to make sure he has his vitamin D supplements, things like that, but I'll measure him first. And when he came back, he had a level like 97, 98, which is near enough 100, doctor. And I said, are you sure you don't take any vitamin D? And he said, no, he takes his aspirin and his heart tablets and all that. And he said, he walked out the door and his wife popped back in and says, do you know what though? Ever since I put him on cod liver oil, he's been an awful lot better.
Yeah.
So I got it. I finally got it.
Yeah, love it.
The only person. Yeah. Now let's go back to the other scenario. Was the so-called BAME. They don't like mentioning that now. They don't like anything. But let us...
Dark-coloured skin.
All the early people who died had dark-coloured skin. And they did another report, a useless report, which found it was every form of discrimination, poverty, deprivation. They didn't mention vitamin D, but I have never seen a dark-coloured skin, black and Asian person in the hospital that I've done, and I've never seen one of them with a vitamin D over 30 unless somebody's got to them first and they're taking supplements. Not one. That was the explanation for the horrendous death rate that we had. And now
of course, it couldn't have been deprivation because it was quite, I mean, there was many doctors.
Well, the first lot were consultants.
Yeah.
So they might argue that they're deprived of something. but
Yeah.
not by everybody else they
Yeah.
were. So that was the first thing. And that was the thing I tried to get through to Whitty.
Yeah.
And again, I mean, the guy is just, I mean, he really is totally unfit for purpose. I mean, why he hasn't been sacked or why he hasn't resigned, I have no idea. He's absolutely dreadful. He kept saying again and again there was no need for vitamin D, like he didn't need to know about it.
Yeah,
There are
I'm pretty sure I got a message through to Chris Whitty via various political figures as well. I'm pretty sure it got through.
I know Grimes and Anderson did too.
Yeah.
But at any rate, there are 4 papers out there in retrospect showing that the vitamin D had a better protection than any of the vaccine programs.
Yeah.
And the one that I think is the most important was a big Spanish study which revealed that there's a lot of vitamin D deficiency in Spain, which I would not have thought it is. They avoid the sun, and then when they're young, they get leathery skin, so they have significantly. And they did a retrospective study of everybody admitted to hospitals who were ill of COVID. So they looked at everything. And the only conclusion, a meta-analysis, was it was really simple. If your vitamin D level was below 30 when you went into hospital with COVID, you had a 77% chance of dying. If it was over 75, you had a 2% chance of dying.
Wow.
I don't need to bother my statistical department's heads in order to work out how significant.
No, even I can cope with that one.
It was unbelievable.
Yeah. I love this microbacterium that you give. So it's a simple microbacterium that you kill it and you inject it, and that produces a broad spectrum immunity against a variety of viruses, potentially influenza, potentially COVID.
Well, the reason it does it is because it boosts the innate immune response.
So presumably the government are biting your hand off to get the recipe for this, are they?
I told them all about it, and I mean, once again, you couldn't make it up. And I couldn't believe this. Chris Whitty said there wasn't enough animal work done on it. It had been in hundreds of patients. We have not had a single SAE. Another example that is not fit for purpose.
What's SAE, sorry?
Serious adverse event.
Yeah.
So I mean, there's many of those. I mean, it actually,
in other words, it's a very, very safe vaccine.
So very, very safe. Unlike Pfizer, where if you go back to the VAERS data that was released, basically, if you had a serious adverse event 3 or 4, which means serious, you had a 3% chance of dying. Well, nobody would give a vaccine with a 3% chance of dying with an adverse event, but it was covered up. It was only released, as you know, a court demanded that on freedom of expression that it be released, otherwise we'd never have known about it.
So you're just using this vaccine in your own clinical trials at the moment, are you?
Yeah, well, there's other people using it in clinical trials now, and I mean, I published a definitive one. I said I was the lead author because it was my idea to do it, and we had lots of different centres around Europe, and we showed that if you give it with gemcitabine to people with pancreatic cancer, metastatic pancreatic,
that's the drug you give with it.
Yeah, that was then in those days the standard drug, and give it with, randomise to just standard treatment alone, then the improvement in progression-free disease and survival was enormous.
Progression in what, sorry?
Progression-free survival. It means they don't...
in what condition?
Pancreatic cancer.
Pancreatic cancer, right.
It's a dreadful disease. I mean, it kills...
terrible.
It kills 80% of people within the year, even with good treatment. So this was highly important. And this is again why I got furious with regulators, because this was a trial that was 110 patients, randomised, produced a fantastic result, no side effects. All they wanted to do was to do a much bigger, more expensive trial that the small company behind it couldn't afford to do.
Yeah.
We should have allowed that to go through with post-registration monitoring.
Well, in England, we have such phrases as park an idea, kick it into the long grass. That they come to mind. So this microbacterium, you inject that with a drug, and that can be effective against some forms of pancreatic cancer, is the contention.
Well, basically, see, what it does, it boosts the declining innate immune response, natural killer cells, gamma delta T cells, all these things. And once you've got those at the front line, then the antigen-specific T cells resurface because we know they're there. Why weren't they there doing their job? Because this is another stream of work I've done a lot of publishing on. Cancer's first job is to suppress the immune response. Otherwise, it couldn't get its head above the water. It'd be attacked. And so it sends out all these suppressive factors. And the older you get, the easier it is to do this, which is why cancer rises with age. And why I think boosting this innate immune response was such a simple thing. It is to the point where because I know it's so the side effects are zero apart from the site where it is, and you'll get a reaction there, but that's a good thing because that means it's doing its job. I actually think you could make a case to give everybody a boost after the age of 55.
I was just going to say, I think I quite fancy this because I suspect I've got several malignant processes. I'm a 66, so I suspect I've got several malignant processes going on in my body now that are just being suppressed by my immune system. And I don't want a perturbation of the immune system, but we'll bring those out. Yeah. Am I right in thinking that?
Yeah, I think you're absolutely right in thinking that. And the body does keep all this under control very well. Until it runs out of vitamin D, and then the innate immune response just gives up. And so give vitamin D and boosting this, I think would keep everybody healthier. It would cost peanuts compared to the madness of this booster vaccine program, for which there is no primary evidence whatsoever. Yeah. It got registered on 20 mice or something, apparently.
The boosters, And
the bivalent vaccines, and they did the mouse experiments. The mice who were vaccinated, when they were challenged, died compared to the mice that didn't get vaccinated. And this is something that's been seen time and time again, and we reviewed in coronaviruses.
So the vaccines have been approved on the basis of dead mice?
They've been ignored.
Oh, I see. They're probably inconvenient, Professor.
Well, this is what it's looking like. And, when you look back at this, it is all horrible. I've tried to be very, my first thing is most cock-ups occur because humans are inherently incompetent and useless at doing things. What I'm horrified at is this. I don't believe is applied here. I think this is far, far worse. This is planned to me. Otherwise, no normal person could continue with this. I was on another thing pointing out to people who've been brainwashed. Who think you've got to have the jab in order to stay safe. And I said, look, the only big example that we have that I believe is relevant was the 1976 Fort Detrick in America flu outbreak, which was a very serious flu outbreak. It was killing young soldiers in their 20s and up to 30s. They did a mass vaccine rollout. They got every company making vaccines and they rolled them all out. It was a flu as opposed to a COVID. And they vaccinated over 42 million people in this program. They were rolling it out. But certain doctors pointed out and said, I'm not sure, but I think I'm seeing an increase in Guillain-Barré after the vaccine program. They reported it. And unlike our lot, they said, really, have you got all your books in the hospital, all your books? They sent people out to monitor it. And they found it went from 1 in 100,000 to 3 in 100,000 to 5. And then they said it's everywhere. And when it hit 9 in 100,000, the FDA, the CDC, all did what they should have done with COVID. They said, is this virus still killing people? No, not at all. Stop the virus, withdraw it, kill it.
Stop the vaccine, yeah.
And that is what has not been done. And I believe that it would be impossible if people were being competent, good doctors, working along the thing as we've always been saying, been taught, first do no harm. And I can only come to the conclusion that this is financially driven. And I believe that all the governments are being corrupted by the Pfizer and Modernas of the world, who've actually taken their interference to new heights by nobbling the Nobel Prize Committee for 2 people with the messenger RNA vaccine. When I mean, that is absolutely ridiculous given what's going on at the moment. And give Weissman his due. Actually, if you look at him, he was always worried about side effects, risks.
That's one of the Nobel Prize winners.
One of the Nobel Prize winners. And the people that we do know have been involved in RNA vaccines there's plenty of them deserve the discovery better than that. They're the 2 that were involved with...
Well, I think you deserve one for this microbacterium because you've got a single vaccine that's working against many things. Professor Clancy has developed a very similar one in Australia. Mm-hmm. It's an oral, I can't remember the bacteria now, but it's a non-typable Haemophilus, I think.
Yes. Mm-hmm.
And you just kill it, drink it, goes to the Pairs patches. Pairs patches send the immunological inflammation to the lymphoid tissue in the lung, and it generates mucosal level immunity in the lung. So simple, works against hundreds of different viruses potentially.
It's exactly the same principle.
Yeah.
Exactly the same principle. And the precursor of the IMM 101, which is what it's called, that we give people, was called Mycobacterium vaccae. And that was used for TB. It was developed to try and improve on BCG. And that actually also works orally through the same mechanism. Mm-hmm. Mm-hmm. And the beauty of these things is that the bacterial walls are so complex, you can't really synthesize those properly. They got everything, glycolipids, all sorts of proteins there, in just the right measure to stimulate the immune system. Because remember, the immune system's seen all these guys before, as it were.
Oh yeah.
It's re-priming them. It says, these are the guys you're forgetting about, remember. And in order to do that, it's a broad response, not a highly specific response. I spent 10 years doing cancer vaccine trials, which I was always suspicious about because I was working with these things and realising I was getting much better response with these. But the industry and all the experts went for tumour-associated antigens, then tumour-specific antigens, and we vaccinated against these, and you got good short-term benefit, but there was nothing long-term because...
Why bother when you can bunk up the efficiency of the immune system with your microbacteria injection? That's essentially a cancer vaccine, isn't it?
It is the best of the lot. I make no bones about it. It makes far, far better. But the big companies like Roche spent a fortune on NY-ESO that said this is the cancer vaccine. Well, if you've got NY-ESO on your tumour, after you've had 2 vaccines against it...
That's a particular epitope, is it?
Yeah,
a particular antigen.
The tumour goes, I'm coming under attack. I better wind this down. And then it starts growing again. It's resistant to this attack. And it has other tumour types on it. It's down-regulated the core one. So there is no one core in tumours. So actually, boosting the army broadly is far better than trying to take long shots at just one antigen. It's a waste of time.
Yeah. And even younger people who get repeated viral infections, some people will come to me and say, I seem to get a cold every 2 or 3 months, John. What do I do about it? It sounds like this general vaccine that works against multiple different pathogens would be a good idea for them. And, as you say, you haven't demonstrated any serious adverse events from it.
In hundreds and hundreds of patients. I mean, with the vaccae and the IMM, in the patients I've treated, I have not seen any side effect of any worth the note. Oh, yes.
These are 2 variations of the microbacteria vaccine, are they?
The IMM we selected for trying to get it approved for cancer.
IMM.
And it's called Mycobacteria obiensis, the strain. Mm-hmm. But we wanted to make sure there were no hiccups. And the obiensis did the same thing, because I was absolutely sure that it had to be as good as. But it's easier to manufacture and quality control. And
do you think you could make this for less than $120 a shot?
I think you could, yes.
Which is the current price, I believe, of the mRNA vaccines.
Really?
Yeah. I believe so. In the States, it's $120. I think the Pfizer. I think
Well,
they're doing us slightly more.
once you get to that level, I mean, if you're doing it for cancer, I worked out that in cancer, I mean, we tend to prime with it and a boost because it's not an antibody, so you could be. And then if the cancer is very immune suppressive, you have to give it. So, but I worked out that the maximum most of the patients get a year is about 6, and then they can get to do 3 monthly, then 6 monthly. And by the time they're 3-4 years, they can just have it annually, and they maintain the benefit. If you were to give it as it would be a far more sensible thing to give than the totally useless flu vaccine program that endured for over a decade. I mean, I don't believe there's any evidence of any use at all. But everybody I've put on this, they say they never get flu again. So what does that tell you?
Yeah. It means we need to boost the innate immune system.
Exactly. And why the NHS and the people advising it, I mean, I just couldn't believe how stupid the people advising the government were over COVID. But then when I finally got a list of people on SAGE, I mean, I just despaired. Yeah. There was nobody of any sense on that SAGE whatsoever.
Yeah. Listen, people, optimise your innate immune system. This is not brain surgery. It's not rocket science. Optimise your innate immune system.
Exactly.
So simple. Yeah, I've got that. I understand that completely. Thank you.
Well, over the counter, the best way you can do that is vitamin D.
Yeah.
And the next way you can do it is with some form of anti-inflammatory, because we do know that the chronic background inflammation drives cancer. It drives most diseases of the Western world, from arthritis, cardiac disease, brain disease. They're all chronic inflammatory processes.
Would statins be anti-inflammatory?
They are, and that's about their only use.
Yeah.
I don't think they do on the tin, and I must say that David Grimes and Anderson, basically part of their basic research they did into the cover of vitamin D, and that was the story of statins. That's probably the first pharmaceutical con that, one of the really big ones that they got the government to treat everybody for which there's not much evidence that it works. And whatever they say, I still see people who've been put on statins have terrible side effects with muscles and things like that, even the ones they say don't. Anyway, I think the best anti-inflammatories are the natural ones, and you can do it with the foods. Is a non-processed food diet. Get rid of all the processed foods. There's lots of really good anti-inflammatory things out there: turmeric, coumarin. I'm amazed at the.
Just say those two again, please.
Well, turmeric.
Yeah. So the yellow stuff.
And curcumin, yes. I mean,
and curcumin comes from turmeric, doesn't it?
Yeah, that's right. Absolutely right. And they're said to be very good. Well, for the gut, they don't get absorbed that well, but they say they're important if you've got arthritis and all these things. And I buy that. I mean, I think this sort of lifestyle change is probably far more important than trying to identify one particular drug. I really do. And you can have a non-inflammatory diet by avoiding the processed foods and having good, healthy vegetable foods and things like coumarin and turmeric, coumarin, etc., which are widely out there. I mean, sometimes in the Sunday supplements, I find a whole page advertising turmeric or curcumin. I can't say no one's ever told people, but I think that an anti-inflammatory diet and perhaps some pills if you're quite bad damps down inflammation, and the inflammation adds to suppression of the innate immune response. In fact, in my work and in how chronic inflammation drives cancer, I mean, I've edited books on it and written lots of reviews on it, and it is really quite incredible how if there is a cause of cancer, it would be chronic inflammation, because it covers everything. It covers the chronic inflammation of smoking, chronic inflammation of lungs. It covers all those tumours caused by chronic viral infections. So,
well, we've known this for ages, haven't we? So cervical cancer with human papillomavirus.
For years and years and years. And that you get the same process going on in those chronic inflammatory processes that don't have a virus. And so actually...
Like the regurgitation in the Barrett esophagus.
Yeah, everything you can do, that is the next most important thing you can do. And the irony is that in our very detailed work on the mycobacteria, the heat killed, and I think it is the fact that heat killed is a very important component, is not only do they boost the innate immune response, but like a seesaw, it damps down the over-enthusiastic response associated with hyperinfection, skin disease, asthma, all those things are reduced. And I've been saying it with my patients, how they report benefits that we weren't even thinking of, and giving it to them for their melanoma.
Well, next time I'm down, if you've got some spare, I'll certainly roll my sleeve up for some of that, Professor. That sounds it sounds like a really good idea. But as you say, why there should be trials on this? I estimate you could probably produce this in mass amounts for £1 or £2 a shot.
I think that you probably could. Actually, it's the vialing that it costs money. and paying someone to inject it. But I could train people up to do the injections. That wouldn't be a problem. Yeah. Professor Dalgleish, thank you so much. If you've got time next week, I'd be fascinated to get some of your views on viral origins as well, if that's a possibility. But for now, your time is precious. We've been sitting at the feet of one of the most qualified doctors in the country, and that's pretty important to me. So thank you very much. Thank you very much for listening.
Thank you.
Bye.
Bye. Thank you.